Hello, good morning, good evening, or good afternoon, wherever you are. At the moment, I'm at Grand Cliff. I'm in the sunny island and the beautiful island of the gods in Bali. So we're going to do an airway and patient positioning video. As you can see, I have my PPE on, my gloves, my glasses, and a spare mask with a gloves as well too. So most important thing about airway positioning, if we go back to like sniffing the morning breeze. And when we sniff the morning breeze, we open up our airway through here. This forms up the tracheal axis. Now, we should maintain a nice horizontal pharyngeal axis when we open. So the laryngeal axis can be adjusted because of our neck position, the shoulder position, along with our oral axis, which is vertical. So we need to look at all these things, but we need to look at the patient. So we have to do a mask ventilation. Then obviously we're going to look at the mask too. As you can see, I haven't shaved for 2 days because I'm relaxing before I go back to work next week. So we look at the mask too, how it's going to fit. We look at obstructions that may be present or obesity in the neck. Is the person over 55 years of age? Obviously I am. Do they have no teeth? Well, I still have my teeth. Do they have stiff lungs or any subcutaneous emphysema or any type of surgery they had around here? These are the things we have to look at for mask ventilation. So then we look at we use the lemon mnemonic if we want to intubate. So again, we look and we assess. So we evaluate using 3 fingers. Does the mouth open? 3 fingers. Do 3 fingers come from the tip of the mandible to the laryngeal floor there? Do the 2 fingers go from the laryngeal floor to the prominence of the cartilage? These are assessments that we have to take in. So we look at the Malapati score, class 1, class 2, class 3, or class 4. Class 1 is that upon opening of the mouth, we can visually see everything in sight on the soft palate. The tonsils of the pillar, the uvula. When we then go for a class 2, we can just see the soft palate and visualise and the uvula. When we go to class 3, we can just see the soft palate with no visualisation. Or class 4 is we can't see anything. These things we need to look at and evaluate. Obviously for me, I'm probably a class 1 or a class 0 because I've had my uvula removed along with my tonsils, so there is a huge opening there to intubate or put a LMA in. So from that, we then looked at if the patient may need a rods assessment, which is for LMA. So we look at have they had a restriction of the neck movement, or now we look at those things. Obesity. We look at deformity. We look at any type of surgery or stiff lungs or C-spine injury that they've had. So, from the Moans, Lemon, and the Rods assessment, we then need to assess the neck in case the patient may need a front of neck access. So that we use the short assessment. Have they had surgery before? Have they had hematoma here in this area? Have they had radiation, trauma, or any subcutaneous emphysema or tumour in that area? These are the things that we have to look at before we implement an airway procedure or anything. So once we have to take in consideration young patients, patients with disabilities, or patients with protruding jaw or short neck. Also, people like, in this day and age, we have a lot of young males with beards, the hipsters of society. So we have to be mindful of all those things. So what I would like to do is then now position myself on the bed, and then I'll show you about methods that we can do to make the view of the larynx better by ramping. Okay. So, if we look at the way I'm positioned now, we have a pharyngeal line running horizontal through. But there may be some difficulty in seeing the laryngeal line with the oral access. Right? So we may have to then support our neck to give that under the shoulders, give that little bit better view. And also place some towels under the head. So we're looking for an easy view, a small angle that we can just open the mouth, put the laryngoscope in and view down there easily without having to put pressure on the laryngoscope or the teeth or any type of neck that we may have to be aware of when we intubation, or applying all the airways or front of neck access. So as you can see, the front of neck access can be attained easily. We have a good view down here. We can mask ventilate because there's only a short amount of stubble on the face at the moment. So, I'd like to thank you for watching this video, and see you next time when I'm working around Australia or overseas.